Okay, welcome everyone. Good afternoon. Excited to have so many folks in person, and it looks like we have a good amount of folks online as well. So welcome to what's hard to believe is November of 2025, our Tobacco Research Programs Seminar. I'm Dana Carroll. I direct the tobacco research programs here, and I co-chair the seminar series with Dr. Alexandra Alchiva. So welcome. So in a world where public health challenges are constantly evolving, don't need to say more than that, we really need visionary experts, people who don't just study problems, but are actively designing and testing the solutions to protect our communities. So today's speaker, Dr. Megan Piper, is a leader and a researcher doing exactly that in the field of tobacco prevention and control. Dr. Megan Piper is a professor of medicine in the Department of Medicine at the University of Wisconsin School of Medicine and Public Health. And she's the director of the Center for the Tobacco Research and Intervention. Dr. Piper is a former president for the Society for Research on Nicotine and Tobacco, which is really exciting. And she's a former chair of the NIH's Interventions to... Okay, very important. She's a former chair of the the NIH's Intervention to Prevent and Treat Addiction Study Section. In 2022, she was named a fellow of the Society for Research on Nicotine and Tobacco, and she's a co-author of more than 200 papers. And based on her most recent CV, I believe it's 203. With more, I think, in review and preparing to be released soon. In her early days, she collaborated on the Public Health Service Guideline Treating Tobacco Use and Dependence, which was published in 2000 and updated in 2008. And largely how I view Dr. Piper's contributions, one of her tremendous contributions is really understanding, measuring, and treating tobacco dependence and nicotine dependence. For some context, here at Minnesota, we have the Minnesota Nicotine Withdrawal Scale. In Wisconsin, due to Megan's contributions, is the Wisconsin Inventory of Smoking Dependence Motives, or WISDOM. Megan has also been a leading authority on measurement of abstinence in clinical trials of smoking cessation interventions. And so these are some guidelines that the Society for Research on Nicotine and Tobacco put out that I'm sure many of us cite in our grants. And related to her talk today, she also has expertise in optimizing effective intervention components for smoking cessation. So please join me in giving Dr. Megan Piper a warm welcome.
All right, can folks hear me okay?
Yeah.
Okay, great. Well, thank you very much for the invitation to come and talk to you. We talk about the Minnesota group and the Wisconsin group, and it's always in glowing terms unless the Gophers have played the Badgers in some sporting event, and then it might be different. But yeah, no, I'm really excited to be here presenting, and I'd love this to be as interactive as possible. So if people have questions or they want to talk about something as I go, please stop me. Happy to do that. So what I want to talk today about is optimization. Optimizing interventions, whether it's for tobacco or anything else. How do we move beyond the kitchen sink approach to develop effective smoking cessation interventions in primary care, something that could actually be used? I want to start with noting my funding. My research is typically funded by NIH, PCORI, and the University of Wisconsin. What I'm talking about today is all funded by the sources listed here, and I've not received any funding from tobacco or e-cigarette industries. We all know this, right? There's a huge public health toll of smoking, and it's possible that it may rise given the lack of no longer, CDC Office on Smoking and Health is gone. And so we may be seeing more and more people smoking. Anecdotally, I've heard people talk about college students thinking it's a great aesthetic to smoke. So it is in some populations unexpectedly rising. And it still results in 500,000 deaths every year. It's the leading preventable cause of death and disability. It still costs $240 billion, and it's still striking populations who would sometimes have the fewest resources to combat tobacco-related disease. So we have this treatment conundrum. We're stuck in this spot right now. We know that 70% of patients who smoke see a primary care provider every year, but very few of them actually get smoking treatment. We know that 50% or more try to quit every year, but the vast majority relapse and the vast majority don't use any of these treatments. But we do have treatments that can double or even triple chances of success, but we haven't had a new treatment in 20 years. Now, in theory, cytisinicline is coming. The FDA has said early 2026, but as we were talking in our group earlier this week, it's a regimen, right? You think 2 pills for varenicline is bad, try 3, right? Who can get 3 pills in them a day? That's a challenge. So what are we going to do? How do we make the most out of what we have so that we can be as effective as possible given the tools we have? This is where intervention optimization comes into play. So multi-phase optimization strategy, or MOST, was developed by Linda Collins when she was thinking about treatment development in a way that engineers think about toaster development or microwave development, right? You don't just study the thing, you look at the different parts and the pieces and you try to optimize the different aspects of the machine. And so using that kind of engineering-inspired framework, we can talk about how we develop, optimize, and then evaluate interventions using that different paradigm. And so she's written a couple of great books about MOST and some extra references here if you're interested. And one of the goals of treatment development, right? It used to be, we want to know, is the treatment better than placebo, right? And typically, if you think back to just drug trials, is the drug better than placebo? And it becomes a horse race, or is a CBT intervention better than an ACT intervention? And it becomes a horse race. And that's part of where we fall off that implementation cliff, right? We have one is better than the other in a rigorously controlled RCT setting. And so really when we're trying to develop treatments, we're trying to find something that is equitably effective for real world populations. That means the last thing we want to do is introduce a treatment that actually advantages people who are already advantaged in many ways. So we want something that's equitably effective. It has to be easy to implement in real world settings. I was a big, Mayo has that amazing in-person treatment for 5 days. Well, they'll help you quit smoking, but very few people can implement that, or pay for it. It has to address key mechanisms. Why do we think something's going to work? How would we put things together so it actually uses mechanisms that make sense? And again, the sufficient use of resources. Who's going to pay for this? If you're going to build this intervention, people won't get to it if they don't have a way to pay for it. So intervention optimization is not a design. It's not a factorial study, right? That people get those things conflated. Intervention optimization is a process of achieving a strategic balance of effectiveness, affordability, scalability, and efficiency. That's the definition. So it's how do we build and evaluate interventions so that they meet all of those goals. It's not about finding the best. It's not about who wins the horse race. It's about finding the best that you could actually implement in real world based on who is willing to pay for it. Does staff have the time to do it? How complex is the intervention, both for staff and for patients? And how acceptable is it? So what are some benefits of taking this approach versus just putting together all the things that you think would work in sort of a classical approach? Well, one thing is you can identify intervention components that aren't effective. It may be that people are spending a lot of time doing something that's actually not effective, or we're paying for something that's not effective. What if one of the interventions interferes with something else? If you're having people, let's say, manage their cravings by, doing a specific type of exercise, but then you also have them restricting their environmental exposure so that they can't be outside to do a particular type of exercise. Now we have things that are butting heads and actually making things less effective. Or something that just costs too much to justify the effects. If you have to send people home with an expensive CO monitor, is that giving you enough intervention success to justify the cost? So we want to identify the sets that have the best value in terms of economic value, and then the ones that provide the greatest effectiveness, even within a given budget. So let's say we have this amazing Cadillac of interventions, but no health insurance is going to pay for a Cadillac, but they'll pay for a Camry. What can I get that's like a Camry? That's really nice. It's not a, I'm trying to think of the, the lowest end, it's not a whatever. But it's solid, but it's not a Camry, or it's not a Cadillac because they won't. So this is how MOST works, right? In a classical design RCT, you just take everything in the kitchen sink and you put it together and you say, all these things have been shown to be effective. I bet all of them together will really just help this person quit smoking. And that's not how the MOST process works. MOST starts with preparation phase. where you are laying the groundwork. You are thinking about, what's my conceptual model? Why do I think these different components are actually going to exert effects and help someone change behavior? Then I identify the set of candidate components based on my model. I might conduct some pilot work to make sure the intervention components are feasible and acceptable. And then I identify my optimization objective. What is the goal I'm searching for? The most smoking cessation rates that you can get for under $500. Something that could be done, most successful cessation rates that can be done remotely with not having to have any physician interaction. So then once you've done that, you've laid your groundwork, then you move on to optimization. So this is where you build the intervention. You're conducting optimization RCTs. So these can be of many different designs. The one that you hear most about are factorial experiments. We also do fractional factorial experiments. I will own that probably I'll never do one of those again. You'll hear about why in a minute. You can do a SMART design, a sequential multiple assignment randomized trial. You can do micro randomized trials where somebody gets a prompt every couple hours and they're randomized each time they get that prompt to different groups and different experiences. System identification and other designs. So whatever design it is, it's to give you the information that you need to be able to figure out what do I know about these intervention components and how they work together. And so you identify the intervention that meets the optimization objective. And if you've got it, is it expected to be sufficiently effective? Then yes, you go on to the evaluation. You confirm the optimized effectiveness, and you do it in a traditional evaluation RCT. This is where you do optimized versus usual care, or optimized versus what's standardly being done in your setting. But if it's not, if you hit a roadblock and it's not going to be sufficiently effective, there's not signal there, you go back. You'd use the resource management principle to think about, what else do I need to be doing? Where did I miss the boat? And if you don't have information on mechanisms, you don't know where you missed the boat. And so that's one of the reasons understanding mechanisms is so critical, especially in research where you don't have a significant outcome. And I can get started on a mediation high horse about, the wonderful contributions of some mediation approaches, but they really did confine us to thinking that you only did mediation if there were statistically significant effects. And that is actually not the case. And then if you, again, going back to the evaluation RCT, if it really works, oh, you're done. You can retire, except in optimization, you keep going. You have something that works well, but could you make it even better? And that's where you go back and you do another cycle. What else could we learn? How else could I improve interventions for people? So factorial designs are incredibly efficient designs. And so Linda Collins started working with us at the Center for Tobacco Research and Intervention right as she was starting to develop most. So she ended up having a meeting with Tim Baker and Mike Fiore, the founding directors of our center, and they got going on this, and it was really exciting. And she came to talk to us about a factorial design, and I thought, okay, I have to wrap my brain around this, but now that I understand how well it works, I love these things. These are amazing. First thing people get terrified about is, how am I going to have enough power, right? So how is this even going to work? But if I were trying to look at 5 intervention components, if I wanted to just do 5 individual experiments, so condition A versus control, B versus control, C versus control, D versus control, and E versus control, I'm going to need 2,560 participants to be able to do those 5 experiments, and who knows how long that will take me. And I can't estimate the interactions of these different 5 components because I only tested them against control. Now, if I do a comparative effectiveness experiment, then I have my 5 components and I have controls, I have 6, and I can bump my N down to 1,500, but I still can't compare these things to one another because I just compare them to control or to each other. If I do a factorial experiment, I only need 512 participants in a 5-factor trial, and I can figure out, do A and B work better together? Do they actually interfere with each other? I can look at all of those interactive effects in addition. And if we want, we can talk about fractional factorials, which basically means you can study 5 factors, but you actually use half the number of, same number of participants, but half the number of experimental conditions by aliasing the higher order, like the 4th and 5th order interactions. And so assuming they're negligible And then you'll able to do all the other analyses the same. So what does a factorial design look like for those that aren't familiar with it? Because the other thing is people think, well, 5 factors, 32 conditions. So you're comparing 32 different conditions to each other. That's not how it works. If you want to understand the main effect of factor A, you take the average of the first 8 and the average of the second 8, and you compare those together. So I get to use the full 512 participants for every single main effect and every single interaction. So my power doesn't differ because I'm looking at all of these different factors. It's the same because I use all participants in all of the analyses. And then you can see how factor B would work. You would use the average of 1 through 4 and 9 through 12 and compare that to 5 through 8 and 13 through 16. I want to say one other thing. Implementing something like this, we wrote a chapter in one of Linda's books because people look at this and say, how in the world do you implement 16 factors? Computers, right? You can set it up. You can assign someone to, your computer randomly assign someone to one of the 16 conditions, and then the computer database tells you what they're supposed to get. And using computers, we've had health counselors. One of the things Linda likes to brag about with respect to implementation is we implemented 80 different intervention conditions during a single center grant 5-year period. And we just did it because we just let the computer guide what the interventionists provide. So optimization experiments, they identify the promising components and look at how best to combine them. So you look at the main effect trends, you can examine the interactions, you can look at the mechanisms and moderators of the individual components, so not just the kitchen sink. If something doesn't work and you have a kitchen sink approach, you don't know why. But if something doesn't work and you have done some sort of a design like a factorial design, you can look at how those components work. And I'll show you how we did that in a minute. The other thing that's interesting, and I thought of it as cheating for a long time, but I've come around. When you're optimizing something, you are not drawing conclusions. So that means you are not beholden to the P less than 0.05 convention because you're not trying to draw conclusions. You're trying to optimize. You are trying to create a best testable hypothesis of what the optimized condition is. We still use or try to use, P less than 0.1, illustrating perhaps there is a reliable signal there. But you don't have to use the P less than 0.05 when you're trying to figure out what components I would combine to be optimized in my intervention package. And again, you pick those intervention components not just based on the most effective, but you're using things like how much time is this going to take? How much is it going to cost the payers? How much time does a participant have to engage? And, we can also put something in there in the optimization criteria that says, I don't want any components that are ineffective. So if something does not show a main effect or something does not interact with something else, if it looks inert, I don't want to include it in the package. So when we think about this, I've described a lot of this, but if you compare the classical paradigm, AKA the kitchen sink, versus most, the objective of the classical paradigm is to develop a really great intervention that demonstrates a statistically and clinically significant effect using an RCT. That's how we've all been trained to do clinical research. Whereas with most, it's to build an intervention that strategically balances effectiveness, affordability, scalability, and efficiency, and can be shown to be statistically and clinically significant in an evaluation RCT. So it's sort of a 2-step objective. And once you've identified something, after you've identified and pilot tested the components, the kitchen sink, you just put it together. You take the research that you've got, you put it all together, and you give it a whirl. Optimization and testing happens once you've identified the components in most. You don't dive into putting everything together and comparing it. You try to figure out how effective, cost-effective, feasible and scalable is it. Experimental designs, primarily it's an evaluation RCT in the classic approach. So 2-arm, 3-arm maybe. Whereas in the optimization phase, you can use any of those designs we talked about earlier. Factorial designs, smart designs, micro-randomized trials. And then the classical paradigm with respect to including inert or counterproductive factors or components, they don't speak to it really. Traditionally, it doesn't matter. If it's in the kitchen sink, it's included. But generally in intervention optimization, we don't tolerate inert factors. And so scalability is also usually dealt with after evaluation in a classical paradigm. So we've created this amazing intervention and it requires 20 in-person visits. Yeah, that's fantastic. And, maybe that's one of those last ditch treatment opportunities for people, but it's not going to be feasible to implement it. Whereas most is actually intentionally built and designed for implementation. It's designed to be scalable. So what I want to share with you now, we've sort of been through intense intervention optimization and how it's done generally. What I want to talk to you about is how we've gone through a full cycle of most, and we're halfway through another one. So we did some optimization experiment. We did a couple of them, and then we did an evaluation RCT, and we're back to optimization experiments. So the conceptual model for this work is based on the phase-based model of cessation. And this model suggests that there are 4 different phases, not to be confused with the stage-based model or anything like that. It's just this idea that each of these different phases has specific opportunities and challenges. And so we want to take advantage of the opportunities, and we want to try to address those challenges to optimize people's ability to quit. So in the motivation phase, which would be maybe 3 weeks prior to actually beginning a quit attempt, specific phase challenges, lack of motivation, lack of self-efficacy, lack of access to interventions, things like that. The preparation phase, which is 2 to 3 weeks prior to the target quit day. What are the challenges there? What are the opportunities? One of the opportunities is maybe this is a time to give people a chance to try something out, try some interventions, see if they think that they'd be feasible or that would work for them. Cessation phase, the biggest, and we sort of arbitrarily set that at 2 weeks because of the fact that most withdrawal clinically peaks within the first 2 weeks, and that's when most relapse happens. So really the goal there is to minimize withdrawal, especially craving, and to help people recover from lapses if they've lapsed, or get people who haven't been able to quit on the quit day to actually, establish initial abstinence. And then maintenance is to get people to recover from lapses, right? That's the opportunity there, is maybe somebody could be rescued by using something. So with that, we looked at the optimal way for the optimization RCT that I ran was focused really on the preparation phase and the cessation phase. So in the preparation phase, we wanted to look at the patch, nicotine gum, and counseling. What can we do in that 3 week prior to the quit date that would really optimize people's ability to be successful? And in the cessation phase, we looked at different durations of combo nicotine replacement and different types and intensities of counseling. And I'll show you what that is in a minute. So we did this optimization experiment with 637 people. It was a 6-factor design. So every factor is either on or off. So it's just 2 levels of 6 different factors. And we did do a fractional factorial. So we reduced it down to a totally manageable number of 32 treatment conditions. But it still allowed us to test the main and 2-way interactions. So what components did we have? Some people, half of the participants, got 3 weeks of nicotine patch and prior to the quit date, and some got none. Another half were randomly assigned to 3 weeks of gum, and the other half of that group did not have any. So what that means is a quarter of participants got patch and gum pre-quit, a quarter got one of the other of each, and then 1/4 got no pre-quit medication. So that's how you cross those factors. So people could have gotten counseling, intensive counseling that would include practice quit attempts and reduction counseling during that 3 weeks pre-quit or not. They got either 8 weeks or 16 weeks of combo NRT. They got intensive in-person counseling or minimal, or they got, and then they were randomized to 2 levels of phone counseling, intensive or minimal. And we had to figure out how to cross those counseling designs so that, people who got intensive on both didn't have them on the same days, right? Because again, all of this was focused in the first 2 weeks post-quit and 1 pre-quit. And so looking at, this would be another example of, is the kitchen sink the best thing? Do you really want 6 to 8 counseling calls, or is 3 to 4 something that is actually effective and maybe more cost effective? And so when you think about it from a condition perspective, so when people in condition 1 got the pre-quit patch and gum, and they did not have any of the pre-quit counseling, they got their combo meds, so patch and gum for 8 weeks post-quit, they had intensive in-person coaching and the minimal phone coaching. So that's how that sort of all crosses itself for people in condition 1. So who'd we enroll? Like I said, we had 637 participants, a little more than half were women. 88% were white. We had very poor racial and ethnic diversity in this sample, but they were about 46 years old and smoked almost a pack a day. So what we did, we used general linear models to predict 26-week self-reported abstinence. That was our primary outcome. We found no statistically significant main effects. We were very unhappy about that. But we did find 3 two-way interactions, which was sort of surprising. We found an interaction between preparation patch and in-person counseling. And what we showed was that if you got the preparation patch for those first 3 weeks prior to the quit date, you did much better if you also had intensive in-person counseling. And the same was true if you had the preparation gum. Having that intensive in-person counseling really elevated that. But what we also learned is phone counseling and in-person counseling both turned to intensive was too much. You didn't need to do both, just use one. So when we look at the individual conditions, we can model those. Again, they're not statistically significant. The sample sizes are small, but we can model the abstinence rates for the individual conditions. And the first one we have here is optimized number 1. And so this has preparation patch, preparation counseling, intensive phone counseling, and 8 weeks of combo NRT. Folks that receive that would get about 46% abstinence rates at self-report at 26 weeks. Now, if you had prep patch and gum, as well as prep counseling, intensive in-person counseling, and 8 weeks of combo NRT, you'd be a little bit higher up. But if you threw the kitchen sink at them, if you gave them the highest level of all 6 things, the abstinence rate was only 33%. So here's an example of why the kitchen sink is sometimes a problem, because it actually interferes with abstinence. Now, abstinence is only one of the criteria that we use for optimization, but here we'd say, all right, we don't want the kitchen sink. And so one of the things we wanted to look at was treatment mechanism. Why were there no main effects? What was not going right here? And so, again, Barron and Kenny's mediation model is great in a lot of respects, but it doesn't address what happens if you don't get effects. And so what we started to think about is, if you have a treatment, you want to know what's going on with treatment related to the mechanism. So you want to study that treatment or action model. And then when you're looking at the mechanism and how it influences the outcome, that's more of your conceptual or outcome model. So what's happening when you have no effect? Is your treatment not pushing the mechanism the way you thought it would? Or does that mechanism not actually link tightly to the outcome of interest? Where is it falling down? Where's the problem? And so what we did, and I apologize because you can't read this, it's too small, but we assessed a variety of different mechanisms using EMA, ecological momentary assessment. And we asked people about their smoking, they reduced their smoking, how were they coping with cues and cravings, their self-efficacy, their motivation. And when we studied, and what you'll notice here is that we don't have all 6 on here because duration was not something that was actually manipulated during the time of a mechanism assessment. So that's not on here. Phone counseling didn't move anything. So, okay, that would suggest to me that, again, if I'm trying to optimize, I'm probably not going to use phone counseling on intensive because it doesn't move much. Now, pre-quit gum reduced smoking pre-quit. It increased post-quit gum use, which, again, if we're trying to get people to use the medication more to have increased craving reduction, that'd be great. It increases instrumental coping strategies in the pre-quit period. It increased post-quit coping strategies, and it increased self-efficacy in the pre-quit period. So pre-quit gum did a really great job, lots of good things. And when we look at what pre-quit gum and preparation counseling also did, is when those 2 things were both on, then people really cut back on their smoking. Makes sense, that was part of the counseling. If they had pre-quit gum and in-person counseling, they also had even more increased post-quit coping than you saw with even the main effect of the mechanism of pre-quit gum on post-quit coping. And they also had more pre-quit self-efficacy. So we could really push those 2 mechanisms if we use pre-quit gum and in-person counseling. And then preparation counseling and in-person counseling really increased pre-quit motivation. So now as we sort of understand what each of these different components is doing for people, now we can think about that, how we might want to put those factors together and which components we might not want. We also wanted to examine moderators, right? This notion that you want equitable effectiveness for people. And I will say that I did this, and then as I was doing it, and then ever since, I've thought more about the fact that nobody's ever powered for moderation analysis, right? You are powered for a main effect analysis, and it takes all of the entire sample you have just to do the main effects. Breaking that into smaller groups, you just don't have the power. But one of the things that you can do is look for red flags. If something shows up, even when you have limited power, then you really have something that you need to be thinking about. So we looked at, by creating two-way interactions between the main effects and then three-way interactions with the two-way interactions for all of these variables, we looked at how well individual difference variables and smoking-related variables moderated the different factor effects. And we did find some. And if anyone has insights into this, I would be greatly appreciative. Psychiatric history. So if you look here on the left, the light bars are people who got 8 weeks of combo NRT, and the darker bars are those who got 16 weeks, and this is abstinence rate. If you had no psychiatric history, you actually did a little bit better if you only got 8 weeks versus 16. And those with psychiatric history did much better if they got 16 weeks versus 8 weeks of NRT. So this suggests, of course, that, yeah, we should be thinking about dosing NRT based on people's psychiatric history. And this was just a straightforward question, have you ever been diagnosed or treated for any of these, psychiatric conditions, depression, anxiety, ADHD, et cetera. But then when we look at counseling, that one makes sense. That one I got. This one, the light bars are minimal in-person counseling, and the darker bars are intensive. If you have no psychiatric history, maybe there's an effective intensive counseling for in-person, maybe not. If you have a psychiatric history, you actually do worse with intensive counseling than minimal counseling. And we have speculated about why this might be the case. Could it be that people with a psychiatric history got started in the counseling and then just didn't have enough? And then it was sort of iatrogenic to have them cut off right at 2 weeks. We don't understand it, but it's something that we need to be thinking about as we're building our intervention. We also found smoking heaviness with moderated intervention effects. And if you look at the light gray, that's people who smoked less than 20 cigarettes a day, and dark gray are people who smoked more than 20 cigarettes a day. And if you look at the dark gray bars, these are across the different intervention conditions. So minimal phone and in-person, intensive phone, minimal in-person, intensive in-person and minimal phone, or both counselings that are intensive. Those dark gray bars are all sort of the same. Didn't matter if you were a heavy smoker. If you were a lighter smoker in the light gray bars, then just having one on was the best way to go. So again, thinking about why is counseling not moving things for heavier smokers, but it is moving it for lighter smokers? What's going on there? What does that tell us about, overall relapse mechanisms, treatment needs, that sort of thing? But then we also want to look at cost, right? So we looked at mechanisms. We want to make sure it's equitable. We have to talk about cost effectiveness. So we modeled this based on cost to payers or insurers. And we wanted to do this based on treatment assigned per protocol, not how many counseling sessions you actually attended, but if a health system was actually going to pay for people to go through all these treatments, what would it cost? And then we base that on, we have bachelor's trained AODA provider type folks, and the medication costs using the Medicaid portal. And we calculated the cost per quit for all 64 conditions, again, using modeling. And we looked at the top 10 most effective conditions to see whether any included components that were not clinically effective, had any things that were not clinically effective based on the interactive effects. Because we wanted to make sure that in-person counseling was included if preparation meds were included. Those two have to go together because we know that they improve not only outcome, but they also improve some of the key mechanisms. And we wanted to make sure not to include in-person and phone counseling because those are not effective. They're actually iatrogenic. So remember in the first box here, we looked at abstinence as the optimization criterion. Now we're going to look at cost per quit. So those same groups, optimized 1, 2, and the most intensive, you can see that optimized 1 and 2 actually relative cost per quit are pretty similar. And again, not surprisingly, the cost per quit for the kitchen sink is really high. So again, we don't want to be throwing the kitchen sink at people. It's just too expensive and it's not effective. So what conclusions did we draw from this optimization RCT? We learned that preparation NRT is a more cost-effective way to boost your abstinence rates than giving people an extra 8 weeks in the post-quit period. We learned that when we create these model-based estimates of the optimization criteria, we can get important insight into the effects of different combinations of conditions and what they're actually doing for people. We can use the cost per quit optimization criterion, and it really helps us sort of balance out what would actually be implementable and scalable. And that criterion holds promise for identifying other things that are attractive to healthcare systems. With these data, we could say, all right, what would the modeled abstinence rates be if I wanted whatever I could get for less than $400? Oh, okay, now I can figure that out for you. I have the different factors. I can figure out how to combine them, figure out what would work for less than $400. But we're not done, right? All we've done is figure out what the best possible package could be. Now we need to do the evaluation RCT. Now we have to actually show that this package works better than usual care. So again, we went back to primary care collaborators and we recruited folks during a healthcare visit. They were electronically referred via the EHR to our study. We were able to call and screen people. We try to really minimize exclusion criteria to maximize generalizability in the sample. So really it was, are you smoking at least 5 cigarettes a day, which would make it appropriate for you to use these medications. Make sure you're not currently taking bupropion and didn't have medical contraindications to NRT. And what we did was we had a modern usual care, which was, does this happen in anyone's clinic? Does anyone actually do this? So it's modern fantasy usual care, right? This doesn't actually happen, but if it did, it would be great, right? You get 10 minutes of in-person coaching, you get 8 weeks of the nicotine patch, and you get a referral to Fitline services or a smartphone app. That would be the ideal clinical encounter if somebody said they were ready to go. Optimized treatment. We went with mini lozenges because mini lozenges were really coming out at this point. I should mention this research program has been going on for 15 years. But this is where mini lozenges really came out and they were more palatable to participants. So we switched from gum to that. We went with 26 weeks because we were running at the same time, we were running a parallel optimization RCT, that optimization trial that was a factorial design that was looking at optimizing maintenance phase. And they did find a difference between 8 and 26 weeks. So we said, okay, we'll go with 26 weeks based on the results of that trial. And we had our 3 in-person in-person counseling sessions. We added the 8 phone counseling sessions because those were part of that maintenance phase as well. That was shown in the maintenance phase optimization trial to be effective. And then also the automated calls to get people to use their meds, that was shown to be effective. So this was, now we're in the horse race category. We have components that we know are effective, they're cost effective, we know what they do, and we know that they work well together. So we recruited 623 primary care participants. We had much better racial and ethnic diversity, which was great to see. They were about the same age, maybe a little bit older, and smoking about the same cigarettes per day. And these were our cessation rates. So these are self-report, except for the 26 week, which happened to be our primary outcome. So biochemically confirmed abstinence rates are about 3 times lower. But you can see the modern care group in the red, significantly lower abstinence rates than the optimized treatment all the way across the board. So now, of course, you could say, well, you threw the kitchen sink at them and the other group only had these things. Well, we did, but that kitchen sink was built only with interventions that we knew were effective and cost effective. So there is an intensity difference, absolutely, but that's sort of what we needed to show, is that in primary care, what you usually do can be improved on if you do this. If you optimize interventions, you can really improve abstinence for a reasonable cost among people who are ready to quit. And those odds ratios ranged from about 2 to 3. Biochemically confirmed abstinence rates were a lot lower, but it had the same odds ratio of about 3. We didn't find any moderation of the 26-week abstinence rates looking at demographics, psychiatric, or nicotine dependence. So the things that we'd seen in the original optimization trial weren't there. Doesn't mean they're not there because we are underpowered to detect them, but at least there weren't any red flags. So a smoking cessation treatment optimized via MOST really meaningfully enhanced engagement and treatment, and cessation rates were beyond what modern usual care would get you among people who smoke in primary care. But we're not done, right? Because you keep going. This notion that, oh, I've done it. I've created the best intervention ever. And you can pat yourself on the back and then you have to write the next grant. Now you have to think about what else do I need to know to really maximize people's ability to quit. And what we know is that there are two effective medications. Most two effective medications are varenicline and combo NRT. But what's the best way to use them? People are using them in all sorts of different ways. When should people start? When should they stop? What type of counseling needs to accompany these medications? And so what we did is we created a 4-factor factorial trial to do this optimization experiment to look at medication type, preparation medication again, post-quit medication duration, and counseling type. And I'll get into those specifics in a minute. Once again, we're recruiting patients from primary care. This time we're using, what we learned is that people who, folks who are rooming the patients are busy and they don't like to do extra things when they have their own clinical work to do. So getting them to offer people our study and being willing to sign people up for it was too much. So in our 14 primary care systems, we had an opt-in strategy where we sent everybody who had smoking status as a current in their EHR, so they were in our smoker registry. We sent them a letter said, hey, we have a tobacco care manager who would love to talk to you about tobacco treatment. Feel free to call us. Any guesses about the percentage of people that called us? I think it was like 2%, maybe it was 2 people. It was very low. But then we had the opt-out strategy. And this is what really we have found to be effective. And that is, we had the medical assistants or the folks rooming patients tell people, our healthcare system really cares about folks who smoke. And so a tobacco care manager is going to call you and talk about your smoking and the treatment options we have available for you. And then they have the chance to say, absolutely not, do not call me. You can opt out. Otherwise, everybody gets a call. And the tobacco care manager is actually employed by the health system. So they're not a research person. They're employed by the health system. They can be in the EHR. They can do these things. And so then if the person were interested, we would refer them to their provider. We could get them connected to the quit line. We could do all these things. Or they could be in one of these studies. If they wanted to quit, they could be in one of the cessation trials. And if they weren't ready to quit yet, they could be in a changing smoking behavior trial. And so that was how we got folks connected. Inclusion criteria were a little bit more this time because we're actually using varenicline. So these are folks who wanted to quit, adults, again, smoking at least 5 a day, had to be able to communicate in English, which is a limitation in our work to date. And they weren't currently using any smoking cessation pharmacotherapy and no suicidal ideation. And the other implementation challenge we had to add is because varenicline's prescription, we had to have the tobacco care manager, who was an employee of the health system, talk to the provider and say, provider, can this person use varenicline, yes or no? And if the person said yes, then they were eligible to continue. So the factors. Medication type was either varenicline, which has a 7-day run-in, or the combo nicotine patch, which started on the quit day. If they were in the prep meds condition, they had that run-in 4 weeks pre-quit. Combo NRT, they just used the patch, the 14 milligram patch for that 4 week prior to quit day. Or if they had the standard start, it was just the standard. Post-quit medication duration, and this is again the tricky thing when you have to interact the factors. If you had no preparation meds, then you started your varenicline 1 week pre-quit, and your 24 weeks only got you to 23 weeks post-quit because of the run-in. But if you did have the prep med condition, you had the 4 weeks pre-quit and the 24 post-quit. Combo NRT was just the 24 post-quit, and then the standard was, you can see there. Counseling type, person-to-person counseling, inter-treatment social support, skill training, 4 sessions. Referral support was, again, what we had envisioned of being, if you went to your doctor and they had a really great counseling session with you and they said, here's the quit line and here's smokefree.gov and we could connect you and then good luck and then we'll call you to see how things are going. That was sort of what that was modeled after. So that was the design. And then life. I'm really going to be happy when I can stop putting these slides in my talks. I don't know if you guys have these slides, but they're a lot of fun. This one only has 5. I have one that has 9. Problems. March 20th, we are ready to launch and the world stops turning because of COVID. So we had to stop, we had to reimagine, we had to go back to the IRB, we went fully virtual, we were finally able to launch in November of 2020. Whew, all right, we're doing great. We've got, 7 months under our belt. Pfizer recalls varenicline. So all of a sudden we can't use our varenicline and we have to stop everybody who's currently got it. We have to tell them it's not safe, please stop. We have to offer them combo NRT for the duration of the treatment instead. That was a challenge. Then we could only randomize people to the combo NRT level of the treatment type for that period of time. Finally, in November of 21, we get IRB approval to use the generic from Canada. Now, rather than 1-to-1 on the medication type factor, we have to do 2 varenicline for every 1 combo NRT to sort of catch people up. But we did it. It was great. Then we're at the end of the grant. We have no time and we have no money. And we had to do some preliminary analyses to say, is there something there, right? We have not fully recruited. Is there an effect? There was in December of 2023. And so we opted to stop the trial. So if you're interested, we screened 10,000 smokers. So there were a lot, and 3,000 were interested in quitting. We had, about a third of that passed the phone screen. A lot of them just didn't complete the phone screen. They would start it and bail. If they didn't complete it, it was typically because they weren't smoking enough, or they said it was too much time, or they were currently using bupropion. We had 853 consent, 538 randomized, because we are in Wisconsin and we are nice. And so we consent to things, but we don't really want to do it. And so we just don't pick up the phone late. And then when you're doing a factorial design and you're trying to create a consort diagram, we had this fantastic research coordinator and she figured out how to do this. So basically what you do is this is counseling on, counseling off. And so all of, across the white and blue, they add up to 100%. And so we used missing equals smoking, so we could use all participants. So our analyses had to exclude the 42 people that were getting varenicline during that time when varenicline was recalled. So we get down to an N of 496. It was supposed to be 608. So that was problematic. Again, slightly more than half were women. Our sample's a little bit older this time around. We again had really excellent, at least racial diversity, if not ethnic diversity. So we're real pleased about that. And again, you can see they're smoking a little bit less than some of our other studies, but more than almost 2/3 of them are smoking within 30 minutes of waking. So highly dependent. Preliminary results. This is just what we're getting into. This is really the exciting part. You're looking up here for the bolded. So we have the main effects, the 2-way interactions, and the 3-way interactions, and the 1 4-way interaction. There is one effect because that's how this works sometimes. So our primary outcome was biochemically confirmed abstinence at 52 weeks, and we had 1 3-way interaction that was statistically significant. And so I wanted to look, I'm like, really, there's no main effects? Really? Are we underpowered? Are we just missing something? As you can see, we're not just missing something. Maybe there's a counseling type effect, maybe if you really squint hard and look for something desperately, but there are no differences. And if you look at the interaction, the nice thing is the interaction was related to medication. And that was one of the things we'd actually proposed to do in the grant, is we're not just trying to figure out what the best package is. We want to know what the best way is to prescribe varenicline and what the best way is to prescribe combo NRT. That was one of the key things that we were trying to find, because that's clinical information people need. And so with respect to combo NRT, so this is the standard prep, meaning for combo NRT, you just start on the quit day or 4 weeks pre-quit. It didn't matter what kind of counseling you got if you had the prep combo NRT. If you had standard, meaning you just started on the quit date, really, the counseling was really helpful. But in varenicline, if what you looked at was, if you got standard varenicline, so you started your run-in 1 week pre-quit, you did way better if you had minimal counseling than intensive counseling. And if you had the 4-week run-up, you did much better if you had intensive counseling versus minimal counseling. And so when you look at those effect sizes and you add them together, is an 18.3 percentage point difference, which is statistically significant when you look at the marginal effects. And so trying to figure out how best to do this, how best are we to use these two different medications, we're getting very different signals. So the conclusions that we can draw in this second optimization RCT are that more intensive interventions may not be necessary, right? That extended medication, a lot of that pre-quit, that 4 weeks pre-quit is not perhaps as necessary. We haven't done the cost effectiveness analyses, but I'm guessing it's not going to be cost effective either. And it also shows, though, that smoking cessation pharmacotherapies may benefit from different administration paradigms. So we sort of say use a medication and use it the same way, even though varenicline and combo NRT have different mechanisms. And that's one of the things we're going to be looking at next as we continue to analyze this data, is what are they doing differently? And what does that preparation medication get you in combo NRT versus in the varenicline condition? Smoking counseling content may be part of what needs to be optimized. Really, we're not seeing any main effect. And we thought people were going to be really disappointed if they got this sort of minimal care counseling and they only got to, do just a little bit. People are perfectly happy to talk to you and get a referral. And that's more than enough for some folks. And so this just is another example of ways that continuous optimization can help us identify the optimal ways to use interventions that we already have. This is a huge undertaking, right? This is a series of 3 different center grants. We had an amazing scientific team. We have an amazing research administration core. We had 14 different health counselors and tobacco care managers and undergrads working on this. It is absolutely a huge effort. And this is part of our crew celebrating after our annual meeting down on the Union Terrace, for those of you that have been to Madison. So, and I also want to note that Linda Collins is sponsoring the first ever conference on intervention optimization. So if any of these ideas were interesting to you, there's going to be a 3-day conference in Bethesda. I'll be there as part of that. And it's, again, going to be a fantastic opportunity. There are other most resources if people want. One of the things that Linda Collins and her group make absolutely sure is that resources are available for free. So people can go in, access, use these things, use their different analytic strategies. And so this was us celebrating 32 years at our center. And with that, I think I will stop and open up for questions.
Great, thank you. What a wonderful presentation. I see this work being very practical for health centers to use, thinking about the balance of effectiveness and cost effectiveness. I mean, they don't always go hand in hand. So I think that's really useful. So what questions do folks have? And we'll start with our in-person audience. And Bob, just let me know if anyone online pops a question in the comment box. Yeah, and I'm going to bring the mic just so the online folks can hear us.
Hi. Thanks, Megan. That was great. I'd like to sort of maybe chat a bit about how to think about the moderation analyses and really more conceptually how to come to them. Mm-hmm. So I'm with you in believing that there's a tremendous value in mapping out the mechanistic processes, right? And I'd like to suggest that the moderators are really just another road into the mediational mechanisms. In other words, so the logic model here is that moderators tell us something about what is and is not working in that sort of simple path diagram that you were shown. Mm-hmm. And so maybe sort of thinking in sort of 2 ways. So they tell us either that those mechanistic pathways that we think underlie our intervention either are or are not working well, or are working particularly well for certain groups, or that there are mechanisms out there that we're not measuring that these people are tapping into. And so I was wondering do you have sort of thoughts about that? Do you think about some of these moderators, either that you have assessed, that then map onto some of the mechanisms that you were looking at? Or also maybe just a prompt or an approach, which is to say that we might want to start to think about the moderators that we assess are assessed in part because of the mechanisms we're looking at, right? So in other words, if we think efficacy is a key target or coping is a key target, does that prompt us potentially to look for moderators that might not normally, beyond, there's sort of, a lot of these trials, it's the usual cast of characters because that's just what we're supposed to do. And so I wondered just how you think about some of that, whether there's work doing that kind of stuff in the background.
I think that is a fantastic question. I could talk about that all day. So one of the things we think about an easy moderator is smoking heaviness, right? And we saw that there were some moderation effects there because that would imply that you were perhaps less dependent and that maybe, certain medications would be easier or harder for you. Maybe smoking heaviness is also related to your nicotine metabolic rate, and that would also have implications for pharmacotherapy treatment. We've also seen things, so we've done research that's looked at cessation fatigue differing by gender and differing in what causes it. So men are more likely to get tired of quitting in general, just be exhausted from the process if they're having more negative affect. Women are more likely to become cessation fatigued if they have higher levels of craving. So, if we look at negative affect and we look at craving, we are potentially available to see how we could look at moderated mediation in those pathways. The other huge one is race, right? Skin color per se, the amount of melanin in your skin does not dictate how a treatment should work. But are we missing mechanisms in terms of exposure to external cues? A lot of our research is done in Milwaukee. It's one of the most segregated and redlined cities in the entire country. And so, those folks that are living in predominantly Black and brown neighborhoods have exponentially higher exposure. Well, that mechanism is not built into that earlier analysis. And so we do have to think about when we put a moderator in there, why would we think it would differ? And so that, psychiatric comorbidity is another one. We think it could differ for lots of reasons, and that's why we need to look at it. But I think that is an excellent point, and it requires a level of, sample size and thoughtfulness as you're doing your analyses to think it through. I like, the red flag is nice and easy and efficient, but it doesn't get us everything we need for sure. Thank you.
Folks online, are there any questions? Okay, what about our in-person options? Yes.
I just had probably a basic question, but how are you able to successfully convince, the reviewers to justify doing the biochemical validation at 26 weeks in that one trial versus at 52? I think it was the second one that you presented.
That's a great question. So 26 weeks we were able to justify because 26 weeks is the gold standard. And in that trial, the pharmacotherapy ended at 16 weeks. So with a 26-week primary outcome, we're at the gold standard and we are sufficiently post-treatment that that's not a problem. In the current trial, we had 24 weeks of treatment. And so having a 26-week biochemically confirmed abstinence is basically end of treatment. So we opted to do 52. Perhaps not my wisest moment, but that's what we chose to do. And it's fascinating, right? In tobacco cessation, it's one of the few fields where we say, how well does this treatment work 6 months after you stop taking the treatment? Very few other, pharmacotherapies are assessed based on their ability to have an effect 6 months after you've stopped. And so, that's again, another issue when you think about, well, anyway, I could go into the methodology issues around that. But it made sense based on the duration of the treatment and what the SRNT guidelines for primary outcomes. Good question.
Okay, because of the time, we'll go ahead and wrap up. For those who are in person, feel free to stay around if you have any questions. But let's just give Dr. Megan Piper a round of applause. Thank you.